So my point is, this rehab is basically a need or luxury. WHO has already been mentioned in his document, recent document, that it's neither a luxury nor an optional care. It's a need and preference, and should be person-centric and need and preference based. And it also expected there is demand will increase because of higher expectancy of life, causing high level of elderly, more than 60. And 2050 there will be double of the number, and nearly 25% of the population will be in the world will be around this elderly. So, but the fact is there is unmet need in the rehab, causing mostly in the middle and low income countries. There is a lack of accessibility, paucity of healthcare workers, rehab workers, and higher cost of service, causing 50% only accessible to rehab service. Therefore, WHO launched a program, 2030 Rehab, is in 2017, and they also focused on use of technology in rehab. So, what are the limitations of current rehab practice? Basically, it is centralized, access-based, and inadequate access to post-discharge home and community care, poor data management, healthcare data causing there is maybe inappropriate keeping or loss in the transit and transfer. So there is a need for preference-based is lacking. So there is one size fit approach in rehab causing all a similar format sort of things. Therefore, the loss of data is being important. So benefit of AI, therefore, it can, in healthcare data management, they can collect good number of data quickly, gather, interpret quickly, faster than human being, facilitate assessment and improve the precision decision making, and enable quicker pattern generation, causing less medical error and quick problem solving and logical conclusions. Other benefits like it can offer tailor-made program for specific disability and specific rehab program, and ML machine learning algorithm can be automated and evaluated regularly. All these can be offered need and preference-based person-centric rehab. Telemedicine in AI also help for inaccessible area can be covered by rehab services. So thus all these design a customized treatment protocol. So AI is basically human intelligence is acquiring ability to knowledge, skill, learning, understanding. Artificial is the mimicry of human intelligence, and it is an umbrella concept. It is basically two branches. One is informatics, another is robotics. Informatics is collection of informations, like from the form of and assimilation and analysis all, and application through robotics or maybe otherwise. So therefore, the prediction automation become faster. It has got several components: machine learning, deep learning. Deep learning is basically, deep means the depth of the artificial neural network. It is like human neurons, is statistically modeled artificial network, and neural language processing is the ability to computer understand the human knowledge, human language. So basically difference between deep and machine learning is nothing, is a volume of data and complexity of data. Machine learning lesser data, deep learning is more data and complex data here. And this artificial network, as I said, it is statistically modeled just like human neural network. So it can be applied in various areas, neuro rehab mostly. Abhishek sir has already been described in this talk. So there are various tools and programs. Virtual assistant can reminder and support, and it can be used in stroke virtual system, and motion recognition technology can be used in hand or lower limb also. MS Kinect is a device which can be used movement recognition and movement sensing device for data collection, which can be done from further far areas for tele-rehab. Biomech VR is a stroke rehab for lower extremity. So all the, and exergaming is another low cost alternative. Balance posture, facial paralysis, gait, all these things can be, AI impregnated devices can be used. Proprioception, neglect can be rehabbed by virtual reality model. Upper extremity in stroke, Gentronics on system that can be used. And in TBI also, there are physical, cognitive, intellectual domain has been damaged. So that can also be AI technology can use. Brand project is very interesting project which can helpful in TBI cognitive rehab. By this way, it is actually post-discharge program. There are various tools are used, sensor, lower extremity, upper extremity, and inertia measurement unit also being used. So all this can be fit to the person or can be area, surrounding areas also. AI wheelchair is development which can be used by without any caregiver by AI programming, AI this technology. So robotics is another advancement in, as I said, another branch of AI application. So this is an intelligent device with human movements and etc. positioning can be done. Robots is basically physical equipment which do some change in the surrounding, both physical and mental. These robots can do some effective support also. It has got various degree of autonomy. It may be fully automatic, may be fully controlled, may be mixed. Most of them are mixed. And medical robots are very much helpful in geriatric care and other, it may provide physical, cognitive support in other way. Physically assistive robot mainly support in recovery, movement, transfer, etc. in neuro rehab. And socially assistive robot mainly social support. There are various forms of robot. Robokind Milo is a small robot which can help in autism, young persons, this is Toyota human robot, various forms of robot. Toyota human robot is helps in ADL, elderly. Animal robots in companion robot like it can help alleviate loneliness and depression. Tabletop robot helps in cognitive support to autistic and dementia patients, and mobile telepresence in pre-rehabilitation support. Exoskeleton is already discussed. So this is very important in AI impregnated, designated AI algorithm can be helped in good rehab protocol. Tilt table also associated with programming. Upper limb robotic rehab also can be done. Finger rehab is important here. Assessment of ROM, force, elasticity, movement therapy can be done by program. Sensitivity training can be done. Serious gaming and all done by surface electromyography. In MSK rehab, diagnostic as well as therapeutic protocol can be designed by AI algorithms, and in shoulder, neck, and back rehab protocol designing. And socially assistive robot here helps in motivation, engagement, and adherence to the rehab program. In neuroprosthesis development, machine learning algorithm can be helpful in symbiotic neuroprosthesis and myoelectric control by using brain-computer technology interface. And intelligent prosthesis also needs some programming. And rehab technology, another technology used AI in rehab protocol designing. IVA, intelligent virtual agent, is another. It is a computer-generated animated virtual character which suits to the person. So it can be designed accordingly, and it helps in peer training or human coach, caregiver, care provider. It is not experiencing any burnout or fatigue. It can continue prolonged. It is sometimes more reliable than human. And virtual affective agent is another form of IVA, which is recognize and express human emotion and support the affection. Virtual human rehab psychologist helps in modify according to cultural need of the patient, language, communication, colloquialism, mannerism, everything. So these are virtual humans. Instrumental environment or smart home, these are recent. These are actually sensors used surrounding area. So to collect the data, it can be from remote, and it can be helpful in feedback and also data collection and rehab protocol planning. So combining with this AI, you can continuously monitor the things from remote. AI so to summarize, it can be helpful in examination and cognitive behavior, continuous measurement, risk estimation also it can be helpful. Physical and virtual technology of AI can be useful in rehab protocol. Measurement of body movement, as I said, speech, cognitive function, data analysis programs, automatic measurement and analysis of everyday situations, psychological evaluation, everything can be easily and faster way and accurately, precisely in a protocol manner can be done to avoid error in medical practice. But there are certain misconceptions about AI application. One is AI can replace human caregiver and cause harm to quality of care, but it's not a fact. There are personalized feedback monitoring system. Another is implementing AI is complicated and expensive. Initially, everything is expensive, but gradually, after more and more use, it will be easy to understand and apply. And another misconception is AI is not reliable, but it is not a fact. It is designed and evaluated with rigorous methods of standards, and ethical consideration has been considered. Continuous evaluation by R&D is done, and there are future scopes and opportunities. Situation is low and middle income countries, they are rapidly using this technology, mostly cost and non-ability of healthcare workers. So the remote area can be covered by this technology by using the all sensors and all. And there is scope of research also if there is any limitations. So both advantage and drawbacks of existing system of rehab with future applications and AI-based solution for decentralized rehab care is the area of future research. But there are barriers. Interoperability means combination of data from various sources. So that is required. So because rehab protocol should be made on social and other issues, and including the clinical. So that to be compared and mixed. And data transparency should be there. Black box nature of AI may confuse certain clinicians, so that should be transparent to all. And actionability. Insight of AI should be actionable otherwise, and clinicians should be given free hand to change the protocol if required. So take home is, AI tool can offer an exciting possibility of transforming rehabilitation medicine from one fit all paradigm to personalized, precision-based, decentralized and cost-effective rehab service and delivery model, each and every individual patient to achieve their rehab goal. So there are some studies also done, just showing, and references. Thank you.
Thank you, Dr. Sapan, for the nice presentation. The session is open for discussion.
not just a diagnostic as we see, but very well equipped as well as training and taking this technology to many parts of the country. And I would like to also to invite Dr. Arul Selvan, sir. Both will be presenting about this novel technology called magnetic MRGFUS, basically magnetic resonance guided focal ultrasound, how we can create the lesion through which we can stop the tremor predominant Parkinson's disease. I'd like to welcome to the dais to start with Dr. Vijayan and then Dr. Arul. Yes.
Good afternoon, everyone. At the outset, I'd like to thank the Physical Medicine Rehabilitation Scientific Committee to allow us to present the new innovative technique. It's really revolutionized the treatment of movement disorders. First of all, I should congratulate my colleague, Dr. Vijayan, forming as a team for bringing that excellent, wonderful machine to the Royal Care Hospital. It's really taken up to the next level of the movement disorder treatment. So we are going to, more or less, it's not a very formal didactic lecture. We would like to have an interactive session. So we could stop at any time. We can answer the questions and queries. Meantime, we will be showing a few videos which we have done so far. Almost 60 cases we have done with phenomenal success. Then he will give us some basic principles of the MR-guided focus ultrasound, how it evolves, what are the limitations, and what's the uses and indications. So I'll invite Dr. Vijayan first, and then I'll chip in.
Respected chairpersons and dear comrades. This is the team. It's a team effort. It's not a one-man job. You have to have a team for this, and we built this team, this wonderful team of neurologists, neurosurgeons, radiologists, and of course various technicians. And of course, we won't forget the help offered by our PMR department also in rehabilitating these patients once we get them out of the treatment suite. Now, this is a totally non-invasive method. Now, we all know, I'll give a short introduction about Parkinson's disease and dopamine. Now, Parkinson's disease, as we all know, is due to lack of a chemical called dopamine in the brain. The dopamine is secreted by the substantia nigra, and the dopamine is the chemical of more. When I say chemical of more, it is a chemical of action, it is a chemical of attention, it is a chemical of addiction, and it is also the chemical of award or reward. So it has so many functions. The very fact that we and me and you are all surviving today as a species is because of dopamine. Dopamine is the chemical that urges you to ask for more. If you have a tent, it asks you to have a house. If you have a house, it asks you to build a bungalow. If you have a bungalow, it asks you to get a car. If you have a car, it asks you to get a bigger car. If you have a bigger car, it asks you to get a plane. If you have a plane, it asks you to go. So that is endless. So that is why it is called as the molecule of more. What happens when this molecule is lost, when you lose the chemical? Not only you have what are classical motor symptoms of Parkinson's disease, the classical tremor, rigidity, akinesia, and postural instability, but you also have other non-motor symptoms of Parkinson's disease. Now, of which the most disabling, all these four symptoms are very disabling. Of course, the instability is very much disabling. Now, this technology for you to imagine, this is how we produce the lesion, a small lesion in the brain. Now, how do we produce it? But as school children in your physics class, you would have used a convex lens to focus sun rays on a piece of paper and burn a small hole in it, or use a leaf and burn a small hole in it. Now, it is the same way. Here we focus ultrasound. Instead of focusing sun rays, we focus ultrasound on the brain. How do we know where we focus? We use the MRI. That is why it is called MR guided focused ultrasound. And we burn a small hole. Why do we burn this small hole in the brain? The brain, as we all know, is an electrochemical organ. It contains a lot of chemicals, and also it consists of a lot of circuits. And these circuits generate currents in millivolts and microvolts. Now, that is how you think, you act, you see, you hear, you smell. Everything is based on these small electrical currents generated in the brain via these chemical components. So it is an electrochemical organ consisting of large amounts of circuits. Now, due to lack of dopamine, what happens is there are a few circuits in the brain that become hyperactive. When these circuits become hyperactive, then there is no way of controlling them. If you replace dopamine orally, it doesn't simulate the exact precise mechanism of generation of dopamine in the brain. So that is the reason why when you give Syndopa, the patient get better initially, but later on they develop side effects. Not only they get better initially, they don't get 100% better. It doesn't solve all the symptoms of Parkinson's disease. These sort of therapies were even used before Syndopa, but in a very crude manner. That's called radiofrequency ablation by drilling holes in the skull. But later on, when Syndopa and all the dopa agonists came, this went out of favor. After 15 years of dopa, then again the new technology, deep brain stimulation, came. It offered hope. Now, as the honeymoon phase with deep brain stimulation and Syndopa is over, now ablative therapies have again come. Why ablative therapies have come again? Because one, they are more effective, they are instantaneously effective, and now they can be done safely. Previously, the safety was an issue. Nowadays, the safety is totally taken care of. It's almost 100% safe technology. And touch wood, there are no single major complication reported till date from more than 170 centers in the world performing this procedure. And we are happy to say that we are the only center in India to have started this procedure. This is the timeline. And in 2016, a first case report or case series was published. A randomized control trial was published for essential tremor. Same year, a case series report was published for Parkinson's disease. It was approved for essential tremor. 2019 for tremor-dominant Parkinson's disease, and 2020 it has been approved for all the symptoms of Parkinson's disease, including rigidity, bradykinesia, and what more, if we target a particular region in the brain called as the pallido-thalamic tract, even the balance improves, the gait also improves, which does not improve with medications, nor does this improve with deep brain stimulation. This is one feature which makes it little more better than all the other modalities of treatment. Okay, having done this, do you need to throw away the medication? No. Parkinson's disease is a degenerative disease, so we treat the symptoms, we cannot cure the disease. So it is an adjunct to treatment. The cornerstone of treatment is, of course, medications. This is an adjunct, additional adjunct to treatment. Now, this is how the instrument looks like, the MRI, and this is the ultrasound transducers. It contains 1024 elements, and all these 1024 elements focus ultrasound waves at 650 kilohertz to a particular part of the brain, and we destroy the hyperactive circuits alone with sub-millimeter precision. So with sub-millimeter precision, when the circuits, these particular circuits are destroyed, the patient gets relieved of the tremor, rigidity, bradykinesia, and even more, the patient's gait also improves, though not immediately. After about 4 weeks, 6 weeks, we've seen that the patient's gait also is improving with this technology. So this is how the patient is fixed to the machine with a helmet and the transducer. This is how we make the measurements. We mark various measurements here because these circuits are not classically seen on the MRI. We have to make measurements. But how are we safe then? because the patient does not undergo any anesthesia. The patient does not have any anesthesia. It's only local anesthesia for fixing the frame. There is no general anesthesia. So the patient is fully conscious. He keeps interacting with that. The whole team, we keep on going every 10 minutes, 15 minutes. We go inside the MRI suite and we keep examining these patients again and again to see if the patient has improved, one, two, whether the patient has developed any side effects or not. If the patient has improved and if the patient does not develop any side effects, then we go on to complete the lesion and we completely target that particular area and we burn out a small hole in that area, destroy the circuit totally, and the patient is relieved of his symptoms completely. Now this is another how we mark the areas. This is the MRI, and you can see that this is the target. And this is one important critical area in the brain which is for memory, which is called as mammillothalamic tract. This is another critical area in the brain which is called as the substantia nigra. So like this subthalamic body. And based on this, how do we make it so safe? We have 4 phases in this treatment. At an alignment phase, we raise the temperature to 40 to 45 degrees Celsius. There we know what we have produced because an MR thermography is integrated in the machine. So it shows the temperature exactly. See, this is the target area and this is the area where the temperature has increased up to 42, 45 degrees. So we know, we mark the size, shape and location of this lesion. And then once we are sure we have aligned the lesion, we align the lesion in various things. We align the lesion in axial plane. We align it in this is the axial plane again. We align it in the sagittal plane, and we also align it in the coronal plane. In all the 3 planes, we align the lesion. So once we have aligned, then we go ahead to raise the temperature to this level, 46 to 50 degrees Celsius. At that level, what happens, the patient completely symptoms go off. Even if he has any side effects, he will let you know. We make the patient write, we make the patient draw, because the patient is fully conscious and he is with us throughout. And once we are sure that the patient has become better, there are no side effects at all, then we go on to this phase called as the treat low phase. Now in this treat low phase, at somewhere around 50 to 55 degrees, very rarely we go to this treat high phase. We produce, again we increase the temperature, and then finally we produce this lesion. You can see a dark blue hole and surrounding light blue hole. Both of these can be lesions. How do we verify this? Not only clinically, we also do an MRI during the procedure. So during the procedure, you do MRI, you see a white spot on the MRI at the area which is where we intended to make the lesion. And of course, we are also seeing the patient clinically. Then we stop the procedure. That is the time when we stop the procedure. So though we make the measurements, we mark all the measurements, ultimately the lesion or the target is what the patient guides us to. Why? Why do I say so? Because the patient keeps telling us whether he is getting better or not. If he is getting better, he tells us. If he is not getting better, again he tells us. Then we can move this direction, target, in either the X, Y or Z direction. So in all the 3 directions, we can easily move these targets, and thereby we can finally make the lesion. When we finally make the lesion, it looks like this, and then we can do an MRI scan, and we can also find out where the lesion is exactly. So we are very safe. Since we have marked the critical structures, we have made the lesion, we've seen the patient, we are very, very safe. So it's a very, very safe procedure. This is how we do the MRI. During the procedure, we see these white spots, and then we stop the procedure when we see these white spots. Now, this is all I told. The advantages of this procedure, I'll tell you, it's sub-millimeter precision. So the machine will not allow you to even create a lesion if your target, marked target, and where the ultrasound shoots are more than 1 millimeter. So it should be less than 1 millimeter. So that critical it is, less than 1 millimeter. There are no major complications. When I say no major complications, there are some minor complications which can occur. Few minor complications which get better with time. It's real-time monitoring, no anesthesia, no incision, almost 100% effective and totally non-invasive. Now with this, I will finish this introduction, and I'll ask my colleague, Dr. Arul Selvan sir, to present a few videos of the patients which we have done till date. We've finished about 62 patients, 66 treatment procedures, and all these patients are doing very well, and they're improving over time. Sir.
Thanks, Vijayan. That was a very nice introduction. You have dopamine, don't ask anymore. At the outset, I would like to again thank the organizing committee of the Indian chapter of Physical Medicine Rehabilitation, the Tamil Nadu chapter. So I'll show you some of the cases. As we said, we've done so far about 60 cases, just above 60 cases and 66 procedures. And many of our patients are all doing very well. I hope the videos are working. This is a patient, you could see that he has a tremor predominant Parkinson's disease on the left hand side. So as Vijayan sir said, it is a team effect. Everyone is a part of the team. The videos are not working. That's right.
I feel very good.
Okay.
Better like I feel very good.
Okay. Right.
This gentleman has got a tremor on the left hand. You could see that pre-operative scores and the post-operative scores, you can combine that. Pre-procedure is 119, post-procedure is markedly reduced to 60. And the PDQ score is 13 months later. We have roughly about a 1 year follow-up for all these patients who's done a phenomenal improvement. So the improvement is sustained, consistent, and then it is still continuously going. This is one-off procedure. You don't need to come back again and doing the procedures. This is only one-off. As he emphasized, this is a non-invasive, very safe procedure. Technically, it's, although it's demanding, but it's very, very safe. Very few millimeter precision. So pre-procedure score and post-procedure score is comparable.
Try. Handsome.
You could see that it's decreased facial
How do you feel
expression.
today, sir?
Perioral tremor, right hand tremor.
Okay. Try.
This is another patient. You could see the marked dyskinetic movement. He is a patient of Pakistani origin, now settled in Dubai. Dopa-induced marked dyskinesias. He cannot able to eat, he cannot able to lie down. Very frustrating for him, very frustrating for the family also. He takes only half a Syndopa, he is extremely sensitive for that. The same patient. You can able to see he is eating his chapatis after many, many years. He can able to feed himself. Not only able to eat, he can able to jog. This is in a hospital corridor, he is able to jog. It's absolutely wonderful that the patient is markedly improved. So we have done one side on him. He is coming back after that for the second type procedure also on the other side. We have done on the right side. He's coming for the left side now. Here, post-procedure, this is the gentleman who could not able to significantly having tremor on the right hand, improved on the tremor, bradykinesia. You can see that marked difference between the left hand and the right hand. He had a resting tremor on the right hand, which is almost vanished. You can see his walking. So he has a left hand tremor, which we have not done that address so far. But the right hand, he had a tremor, rigidity, and the bradykinesia, which is markedly improved. Again, the same UPDRS scoring. Pre-procedure is about 169. Post-procedure is 72. And the PDQ scale is also markedly improved. This is another gentleman. Right hand tremor, resting tremor, increase on posture, and also in action. Not only has a hand tremor, he also has a leg tremor also. You see the right hand tremor and the right leg tremor.
Got the lecture.
Post-procedure tremor has improved phenomenally. Can't see the cursors. We are asking to hold the stick on that to see the tremor has improved. And the pre-procedure to the post-procedure. So another patient. He was working as a pastor in one of the Western African countries, somewhere in Namibia. You could see that following the procedure, he could be able to walk very well. The arm swing is much better. Bradykinesia has improved, and the tremor has also disappeared. He sent this photo from his farmhouse there. We'll skip this video. We are testing for the bradykinesia.
Surya.
We're testing for a cogwheel rigidity. This is a lesion, we made it on this patient. You could see that one is on the pyrrhodothalamic tract, another one is in the ventro-intermediate nucleus of thalamus. This is a MR confirming that we have focused ultrasound lesion in that very precisely.
Turn பண்ணிக்கோங்க. Turn பண்ணிக்கோங்க. Then come back. Do this part.
I could see the post-procedure improvement.
You got this? Yes.
I said you can experiment on me, no problem.
You could see that the initial freezing hesitancy and then started running, gait disturbances. Leg tremor,
எழுந்து உட்காருங்க
and then
அப்படி.
you could see some hand tremor also.
Okay. நீங்க இங்க வந்து. Thank you. Keep it like this. Very rich.
So he was bradykinetic. So as we assess during the procedure, you could see that the clinical assessment is a core and important during the procedure. Although DBS, we could do the same thing during the procedure also, but sometimes the patient will be drowsy once you open up the dura and the seizure pressure is varying. But this is a patient will be conscious throughout the procedure, and you can do all the assessment. You can assess the rest tremor, bradykinesia, rigidity.
4, 5, 6, 7, 8. Later putting in. Hold tight. Minus 8. Minus
You
8.
see that foot tremor.
Minus 8.
You could appreciate the tremor is markedly reduced. Again, he had the MRI lesion, very precise, roughly around 6 to 8 millimeters in size. The lesion is one done on the right side of the thalamus for the left arm and left leg tremor.
As many as possible.
Post procedure, you noticed that he had
Slowly turn around.
significant freezing difficulties of the gait that has also improved. The left hand tremor,
Okay. Okay.
the
Stand there.
bradykinesis is also improved now.
Turn around. Okay. And
Just take a couple of minutes. You can able to do the finger nose coordination much better. So the previous UPDRS was 97 on this patient has come down to 21 following the procedure. And there is a much clinical improvement also. Just show you the last few videos and then I'll stop it.
நடங்க. திரும்புங்க. சரி. நேரா பாருங்க. நமக்கு கையை நீட்டுங்க.
So he had a right hand tremor. That's improved on that one.
Just try.
Try to write.
You could see how vigorous the tremor was.
Okay.
It's not only the resting tremor, it's increase in action and posture. Let me show you one last video. This is a video. You see the tremor on the left hand. Post procedure, there was a marked improvement. This is the same patient. Hardly you could notice any tremor on the left hand. This is a patient who had a severe Parkinson's. Again, like a similar patient before, I've shown the videos. He had a dopa-induced dyskinesia. He was taking only about 4 syndopa a day, 110 milligram. If further increase will cause us a marked dyskinetic, unwanted movements on her. You could see that how writing movement, dyskinetic, and sometimes it could be painful for her also. She cannot able to walk.
ட்ரை பண்ணி பாருங்க பிடிக்காம நடந்து பாருங்க
இல்லை கொஞ்சம் இதுவாக இருக்கும் இல்லையா ரிஜிடாக இருக்கிறதுனால.
Same patient, following the procedure. We've done only one at a time. Recently we have done on the other side also.
இருக்கதான் முடியுது ரொம்ப கஷ்டமாக இருக்கு.
So we have done on the left side of the brain, so the right hand and right leg is doing well. Left hand and left leg, she still has some dyskinetic movements. This must be the last video. I'll stop it from here. So to conclude my talk, so MRGFUS is a very novel technique. It's a perfectly safe procedure, very few millimeter precision. We can control it by giving the joules and energy what time, at what level we want it. We did not have any complications so far. Some of the complications are very transient, like ataxia, weakness, temporary weakness. It's all lasted for about 1 to 2 days, and then it's improved markedly. Thank you once again for your patience. Thank you very much.
Thank you, Dr. Arun and Dr. Vijay, for an enlightening talk. And I'm sure it's going to revolutionize the treatment of Parkinson's. You'll get more and more patients. Now the questions from the floor. Any questions?
Yes, sir.
Yes, Dr. Abhishek.
Hi. Are you using the Lexel frame for making the coordinates?
We are not using an Excel frame, we are using a stereotactic frame. We have not shown you on that one.
Okay.
An Excel frame is not used, we are using a stereotactic.
And the ultrasound machine is embedded in the frame system only?
Yeah, we've shown that piezoelectric cell is arrayed in a 360 circle with helmet shaped one. So it is fixed with the table so that the head goes in and then it focuses the array. It's a focused array of piezoelectric cell array in that one.
What is the treatment time normally? It
Treatment
takes
time.
One patient takes
If
1
the
hour?
patient is cooperative, we will be taking about 1 to 2 hours. Because we are doing only one at a time now. We are not licensed to use both at the same time. Being it's a lesional surgery, we may cause a permanent weakness. That's what we are worried about. The US FDA and also the Indian government has agreed only for the one procedure at one side at a time. So we'll be doing only a right or left side only.
You have about a 1 year follow-up. Any change in the non-motor symptoms also?
Non-motor symptoms.
Yeah.
That's a good question. When the dopamine is more, all of the non-motor symptoms also got improved. So many of the patients who had a subtle depression and then constipation, when the mobility has improved, these symptoms are also improved. But we did not document, but there is a substantial improvement in non-motor symptoms. Interestingly, the other side also improves in our patients. We would agree with you, Jain, isn't it?
Yes, sir. Just to add on that non-motor.
Hello, sir. I am Dr. Kaniyar, sir, from Madurai.
Just one minute.
To add on that non-motor symptoms, there was one patient who said that he got back his taste. And I'm not sure, it's not documented in world literature. Till date, it has not been documented. One patient who said he got back his taste. Then there are a lot of patients who say they lose the craving for syndopa. Craving is gone. And then as we showed on the videos, dyskinesias are totally abolished. DOPA-induced dyskinesia is totally abolished. And even if you re-challenge with DOPA, they don't come back.
Parkinson's disease is an extension of Bryan-Capellan. Many of the patients will not have any smell. That's the first symptoms or sign. We'll pick it up. So when it improves, the taste also improves. I think that could be an explanation for the non-motor symptoms.
Hello, sir. I am Dr. Kaniyarasu, a physiatrist from Madurai. Up to what stage you do this surgery of Parkinsonism?
No,
Stages of
that's
Parkinsonism.
depending upon the patient's selection criteria.
Yeah.
Some patient will be in stage 2, but they will be doing a very high profile job. For example, one of our patients is a chief executive in a bank. So he doesn't want a tremor to be shown in the meeting. So he was at stage 2 or early stages, but he wanted to be done to abolish the tremor.
Okay, last stage you have gone?
Last stage, probably stage 3. We have not done any patient with the bed bound at all.
Yeah.
When the patient comes in the bed bound, we directly reject it because it does improve the quality of life. We need to have certain quality of life to achieve that. So if you don't have bed bound, then there's no point in doing the procedure and increasing the mobility.
So up to 3 you have been, sir?
Yes, yes.
Thank you, sir.
Thank you, sir. Any recurrence so far? There was one patient who had a tremor as recurred in 6 to 9 months' time, but that is multifactorial because he is an alcoholic dependent patient. He also had a familial tremor, essential tremor. We have done the procedure, but he gone back and then he was living in the high estates and he was drinking more. So we have to warn him again, and then we've done the procedure again. And then tremor has improved and he's abstinent from alcohol. So he has not recurred so far.
The recurrence rate is around less than 10%. Less than 10%.
Cost, I'll pass it on to Dr. Vijayan.
It's 25 lakhs. At present, we are charging 25 lakhs for one side, and for the other side, when they come, we charge around 5 to 6 lakhs for the other side.
So mainly the consumables is very expensive. The silicon membrane which has been imported from Israel, that alone cost about 5 to 6 lakhs. So the consumables are costing phenomenal amount of money, and then we have to pay the GST over that. And they are very delicate. Compared to DBS, it may be a little bit more or less in the same, because the metropolitan like Bombay and then Hyderabad, they also charge a similar amount. But the patient choose this one because it is non-invasive. You could see the results on the table itself. The deep brain stimulation, we have to do a frequent programming. For example, tremor and all, it will take 1 year. So, and dystonia will take even 1.5 years to see the improvement. Complex programming, networking, and then an invasive. Anybody would not like to have a foreign body sitting inside the brain. We don't know, although there were no infection rates so far, but we don't want your foreign body to be sitting in the brain, and then anytime, that's not the big issues. No, sir, not yet, sir.
No head-to-head studies, sir, as of yet, comparing. This is a very new technology now. Though the lesioning surgery is very old, it's a new technology. The only thing I would say, the results, as he told, are seen immediately on the table. It's a one-off treatment. You need not come back again. Most of our patients, both myself and sir, will follow only on video. We don't ask them. We have patients as far from Jaipur, Delhi, Mumbai, Hyderabad. So we follow them only on video. We don't follow them. We don't ask them to come to the hospital. That is one thing. The gait disability improves with pallidotomy, which does not improve with DBS, which does not. In fact, DBS makes it gait slightly worse. And medications also make the gait worse. But here, pallidotomy and pallidothalamic tractomy improve the gait. That has been documented. That one thing has been documented vis-a-vis DBS, but no head-to-head comparisons as well.
Many patients on the post-procedure, they just cry of emotion because they have not had a useful hand so far for many years. They could able to write, they could able to feed themselves, they can able to shave themselves. It's a very great relief. They don't want to be dependent on other carers for this patient, and they are immensely thankful for that. And many patients have written and then given the documented writing also saying that so they felt extremely joyful and happy after the procedure because they see the results instantaneously. Madam, yes, ma'am.
most of the cases that we have seen the video where either tremor dominant or dyskinesia dominant. Was that a selection by us, or the patient were willing more for going for surgery if the tremor or dyskinesia was dominant?
At present, we are licensed only. We are only for tremor, essential tremor, and tremor predominant Parkinson's disease, dyskinetic movements. We are licensed only for this.
If the patient only has rigidity or the robotic gait only, you don't
It
prescribe
improves,
this.
ma'am. That also improves.
Yes, sir.
Not as good as tremor. Tremor improves more than 90%. And
Okay, that's
stays
what
for
I
many
saw, that
years.
most of the cases were only.
The rigidity and the bradykinesia improves by 70 to 80%. That the gait also improves, but over a period of time. So when we target the palatothalamic tract, it takes care of bradykinesia and rigidity. When we target the VIM, it takes care of the tremor. So it does.
It can be done, but
No, we have done. We've been
Okay.
doing also. As an offshoot, most of the patients have.
And during your speak, you were telling that still the cornerstone of treatment is dopamine, oral drugs.
Yes, madam. Medicine is a cornerstone of
So
treatment.
should we still titrate the medication post-surgery,
Yes,
sir?
madam. Yes, madam. You have to.
The off and on phenomenon will still happen?
It might happen. Sometimes, most of the time, the off periods come down remarkably. Some patients are on 8 tablets, 9 tablets per day. They're taking only 1 or 2 tablets per day now.
Okay.
So that much remarkable improvement. At least you can expect 30 to 50% reduction in drug dosage over a period of 3 to 6 months.
Okay. So the total follow-up, the maximum follow-up was 13 months.
Yes,
here.
ma'am.
What's the worldwide follow-up period? And
3 to
the
4
records?
years. 4 years now from Switzerland. More than 4
Michigan
years.
has got 4 to 5 years, I think.
Okay. When there is a recurrence, you still prescribe another surgery, or we have to.
So
Can be done. Can be done.
Can be done. Second surgery can be done on the
Can
same
be
side.
done. Can be done on the same side.
Okay.
And
Thank
DBS
you
can
so
also
much.
be done. Suppose the patient fails and they want to go for DBS, that can also be done on the failed patients. But we have not done anything so far. Only one patient occurred, and then we have done the lesioning on that one. As Vijay sir said, I think Parkinson's disease is a degenerative disorder. We are not altering the course of the disease at all. We are just giving symptomatic relief. We have to understand that. Many patients will think that you do that and then disease get arrested. No, not at all. The disease progress, the natural course will continue to go ahead. We are just helping them symptomatically. The tremor improves, bradykinesia improves, rigidity improves. Unfortunately, the disease course will be continuing. We cannot alter the course pattern.
But then, for that period of time, the relief you are offering is really magical. Thank you so much, sir.
Thanks.
Thank you so much. After this enlightening talk, can we have you back on the dais so that now, thank you. We'll call upon the next speaker of this session, and Dr. Ramamurthy, in-house speaker. He is the professor and head of Department of PMNR in PSG Institute of Medical Sciences and Research, Coimbatore, and he'll be talking about management of diabetic peripheral neuropathy, comprehensive and holistic approach. Dr. Ramamurthy.
Right. Good evening, friends. I thank the organizer for this opportunity. It's the profile of my institution. I welcome every one of you for this presentation. I'm going to discuss the topic in these headings. Case 1, 48 years old Mrs. M from Salem, a type 2 diabetic for the past 12 years, presented with numbness of both feet and a non-healing ulcer in the right foot over the first metatarsal head region for the past 2 years. She also complains of unsteady walking and her footwear slips off while walking. Her blood sugar values are fasting 165 milligram, postprandial 279, HbA1c 9.8. Case 2, 43 years old Mr. T from E Road, a type 2 diabetic for the past 7 years, presented with burning sensation in both feet for the past 6 months. He also complains of erectile dysfunction for the past 3 months. Blood sugar values, fasting 147, postprandial 286, HbA1c 9.8. So I have presented 2 cases. Both cases are complications of type 2 diabetes, namely diabetic peripheral neuropathy. The first case, diabetic peripheral neuropathy with negative symptoms, numbness, And the second case, diabetic peripheral neuropathy with positive symptom pain. How to manage these cases? So whenever we get a patient, we elicit the history. For lack of time, I'm skipping the history. Assessment of peripheral neuropathy. Whenever you get a case of diabetic peripheral neuropathy, you have to find out whether it's a large fiber neuropathy or small fiber neuropathy. Because the pathology, clinical features, medical management outcome are totally different from large fiber and small fiber neuropathy. Large nerve fibers are A alpha, A beta, A gamma. They conduct proprioception, somatic motor, vibration, pressure, touch, and deep tendon reflexes. When a patient has large fiber neuropathy, there will be loss of vibration, proprioception, position, touch, deep tendon reflexes. So the patient will have numbness walking over the cotton wool or ice. The management, as of now, there is no drug to bring back the sensation. So we advise glycemic control. The duration of the diabetes and the severity of the diabetes are more important. So we insist the patient to have a blood sugar target like fasting less than 100, postprandial less than 150, HbA1c around 6 to 7%. When the patient has persistent hyperglycemia, the following biochemical events will happen, namely increased polyol pathway, increased glycation, increased free radical production, protein kinase C activation, reduction in vascular endothelial growth factor. In hyperglycemia, the excess glucose will be converted into sorbitol in presence of the enzyme called aldose reductase. The sorbitol destroys the nervous tissue. The covalent bonding of protein or lipid molecule with the excess glucose is called advanced glycogen end product. They damage the nervous tissue. A molecule with single electron in the outer orbit is called a free radical. Normally in our body, free radicals are produced and the antioxidants in our body remove them. When the free radicals are produced in excess, that leads to a condition called oxidative stress. In oxidative stress, a nuclear enzyme is activated called poly-ADP ribose polymerase A that will damage the nervous tissue. In hyperglycemia, there is a formation of diacylglycerol that will activate an enzyme called protein kinase C that will again damage the nerve fibers. You all know the blood vessels are lined by endothelium. So the endothelium, vascular endothelial growth factor is secreted. In diabetes, there is progressive endothelial dysfunction and reduction of the vascular endothelial growth factor that results in neuropathy. Okay. So when the patient has hyperglycemia, the nerve damage occurs through increased polyol pathway, increased glycation, increased oxidative stress, protein kinase C activation, and reduction in vascular endothelial growth factor. So in the intervention, so in the management of diabetic peripheral neuropathy with negative symptoms, we have drugs that may alter or slow the progression of the nerve dysfunction. So already we see the glucose is converted into sorbitol in presence of aldose reductase. We have a drug called aldose reductase inhibitor, a molecule called epaltristate available in the name of aldonil. So that will control the damage. Then we have antiglycation products, namely avinoconidine, 300 milligram to be taken 600 milligram per day. Then third one, antioxidants. Several antioxidant drugs are available. The recommendations is the take alpha-lipoic acid at the strength of 600 milligram. Then fourth one, protein kinase C inhibitor. Roboxytaurin is available, but it is not getting approval from the FDA for treatment of diabetic neuropathy. And the vascular endothelial growth factor is not available. Still, it is in the experimental status. So, in the management of diabetic peripheral neuropathy, large fiber neuropathy, these are the management. Number one, glycemic control, aldose reductase inhibitor, AGE inhibitor, and antioxidant alpha-lipoic acid 600 milligram 1 OD. A patient with large fiber neuropathy who has benumbed sensation, he will have a recurrent injury to the insensitive foot. The probability of he or she developing the ulcer, non-healing ulcer, amputation is very high. So your prescription for a large fiber diabetic neuropathy is incomplete without prescription for a MCR footwear and a foot care instructions. So you have to prescribe a MCR sandal or a footwear with a quarter to protect the foot. Why do you prescribe MCR footwear for a diabetic peripheral neuropathy patient. The normal plantar pressure is 80 gram per centimeter square. In patient with diabetic peripheral neuropathy, the plantar pressure will be very high. It goes up to 800 grams. When you give MCR footwear, it will redistribute the excess plantar pressure. Also, the MCR footwear will also reduce the interfacial pressure. Okay. Foot care instruction, you have to tell the patient how to protect the foot. There are 20 points. For lack of time, I'm skipping this. Okay. So this patient was followed up for 6 months. First month, second month, third month, 6 months. There is no improvement of the symptom in spite of all these drugs. So second case, diabetic peripheral neuropathy with positive symptom, burning sensation. So assessment, the small fibers are A delta, B and C. B and C are the autonomic fibers. A delta carries the pain and temperature. So when the small nerve fibers are affected, in the large fiber neuropathy, I told loss of proprioception, loss of vibration, loss of touch, everything. In small fiber neuropathy, the patient will have exaggerated pain sensation. Why? I will tell you at the end of the session. The numerical pain rating scale pain is 9 out of 10. So in the clinical presentation, it may be a burning or lightning or stabbing with a knife. Management. So we have drugs that may alter or slow the progression of the loss of function, like already we discussed, aldose reductase inhibitor, AGE inhibitor, and antioxidants. Therapies for symptomatic relief. The abbreviation TBN stands for diabetic peripheral neuropathy. The DPN stands for duloxetine, pregabalin, nortriptyline. These are the first line of drugs. Okay. The duloxetine is the pregabalin is anti-epileptic. The other two are antidepressants. Pregabalin, the subgroup CABA analog, duloxetine, serotonin, norepinephrine reuptake inhibitor, and this is tricyclic antidepressant. You have the choice. When the patient has insomnia, sleepless leg syndrome, you can choose pregabalin. When the patient is severely depressed because of the pain, you can choose the antidepressant. You can start with duloxetine, you can add pregabalin. You can start with norepinephrine, you can add pregabalin. You can start with pregabalin, you can add duloxetine. You can start with pregabalin, you can add nortriptyline, but never two antidepressants together. Okay. How I treated this patient? The pregabalin recommended dose is 75 milligram to begin with, then weekly interval of increased by 75 milligram. So the patient was given 25 milligram, 2 at night, day one. The patient will have constipation. So always you must prescribe pregabalin with dulcolax. It is a calcium channel blocker drug like nifedipine. It also will produce edema. So you watch for pedal edema and weight gain. Simultaneously, I give capsaicin cream 0.07% that will deplete the substance P from the nerve terminal. In India, we have 0.025%. In Amazon, it is available as 0.075%. After 1 week from 9, the pain scales come to 8. Then I titrate the drug. The patient was given 150 milligram of pregabalin for 1 week. From 8, the pain came to 7. Then again, I uptitrated after 1 week. This time, 225 milligram, 2 at night, 1 at daytime. The pain came to 6. Then again, uptitrated. So 300 milligram of pregabalin, 2 at night, 2 in the morning. The pain has come to 5. It is moderate pain. The pain is not fully relieved. So I added the antidepressant. Duloxetine, it is available as 20 milligram or 30 milligram. I started with 20 milligram night. This drug is produce nausea. You must take all these drugs for you. You take pregabalin. You see how you feel the nauseating feeling and the constipation. You take the duloxetine. It will produce severe nausea. So always we give along with domperidone. So pain came to 3. Then again titrated, duloxetine titrated to 40 milligram at night, and the pain has come to 1. Okay. So 2 important statements from the author of this article: neuropathic pain, quality of life impact, cost and cost effectiveness of therapy. So I taken from the PubMed. Patients with neuropathy pain are usually not prescribed medications with demonstrated efficacy for their conditions. NSAIDs are not recommended, steroids are not recommended, opioids are not recommended, the carbamazepine, we prescribe the Decretal are no longer recommended. The recommended primary drugs are pregabalin, duloxetine, nortriptyline. When you prescribe, when they do receive appropriate treatment, they receive dosage that are on an average far below the dosage with demonstrated efficacy. I told you pregabalin must be given up to 300 milligram. Okay, discussion. The first case, who presented with long fiber neuropathy, benumbed sensation, at the follow-up, no improvement of symptoms. The second case, the small fiber neuropathy, pain relief is achieved. Why? When I did MBBS in the late 70s, we studied pathology from the book, Boyd's Pathology, wonderful book. The author writes in the preface, assess your pathology, so is your practice. If you know the pathology of the disease, you can understand the course of the disease, you can predict the prognosis. So this is a neuron, cell body, axon, and myelin sheath. The hallmark of diabetic neuropathy is loss of myelin sheath and axon. Okay, there will be, when there is any injury to the neuron, there will be disintegration of the myelin sheath and fragment of the axon. When regeneration occurs, the axon grows guided by the myelin sheath, and the proximal segment will meet the distal segment. This will happen when it is a mechanical injury. In diabetes, it is a metabolic injury. Injury occurs all the time. All 24 hours there will be, the patient will have hyperglycemia. So degeneration always occurs. Degeneration, regeneration, degeneration, regeneration. At one stage, the degeneration predominant. As a result, the growing proximal end will not meet the distal end. That is to say, the patient will not get back the sensation again. So established symptomatic large fiber diabetic neuropathy is generally not reversible. So you have to tell the patient, you will never get back the sensation in the feet. So what to do for a patient with a large fiber neuropathy? We have to protect the feet from amputation. We have to protect the feet from developing the ulcer, Charcot neuropathy, and amputation. Vitamin B12 methylcobalamin is not a panacea for diabetic peripheral neuropathy. I am not against the molecule, but it's very expensive. The soft gel, one capsule costs 16 rupees. The injection costs 120 rupees. So some of the prescriptions with methylcobalamin. Okay. So what is the indication for methylcobalamin in the management of diabetic peripheral neuropathy? I'll finish in 2 minutes. Metformin is the denominator drug in the management of diabetes. This metformin reduces the intestinal absorption of vitamin B12. When the patient has proven vitamin B12 deficiency, then you supplement with vitamin B12. 1000 microgram parenterally till he reaches a normal level. Why small fiber neuropathy is so painful? See, in small fiber neuropathy, during the regeneration, the proximal end meets it's a distal end. There is no sensory loss, but the newly grown axon, there will be abnormal electrical discharge from the growing nerve fiber. That's why the patient will have severe neuropathic pain. So take-home messages. Symptom, benumbed sensation will not improve in large fiber neuropathy. So in large fiber neuropathy, the management aims to slow further progression and prevent complications like diabetic foot ulcer, Charcot neuropathy, falls, and amputation. In patients with small fiber neuropathy, burning sensation can be 100% relieved if appropriate drugs are prescribed in adequate dosage. Methylcobalamin, available in the Renerve, is not the drug of choice in the management of diabetic neuropathy. It is indicated only when there is proven vitamin B12 deficiency. These are my references. It all came in July 2023.
Thank you very much, sir, for great presentation. Any question from audience? Okay. Thank you very much, sir. Thank you. Now, our next speaker, Dr. Shiva Kumar, sir. He is a senior consultant in pediatric surgery, Apollo Hospital, Chennai. He will be speaking on new modalities in the management of pressure ulcer.
Good evening, ladies and gentlemen. At the outset, I thank the organizers depicts the huge or enormous plantar pressure of Lord Vamana over King Mahabali. So that is the significance of pressure. In a busy OPD, just by inspecting the color of the floor of the ulcer, we can decide on the management of the ulcer. If the floor of the ulcer is amber in color, it is an epithelializing ulcer, nothing needs to be done, only reassurance is required. If the floor of the ulcer is red in color, it is a granulating ulcer, only saline dressing is required. If the floor of the ulcer is green in color, it is an infective ulcer. The antibiotics has to be started based on the gram staining and culture sensitivity, in addition to the diabetes control. If the floor of the ulcer is yellow in color, it is a sloughy ulcer. The slough has to be removed either manually or by agents like urease and papain. If the floor of the ulcer is black in color, it is a gangrenous ulcer. It requires immediate, sharp surgical debridement and amputation. This depicts the various floors of the ulcer: granulating ulcer, infective ulcer, and a gangrenous ulcer. This bar diagram depicts the 5-year mortality rates of various chronic diseases, out of which diabetic foot, the mortality rate is much higher than many common malignancies. There is rule of 15 and rule of 50 in diabetic foot. 15% of diabetic patients will have diabetic foot ulcers in their lifetime, and 15% of diabetic foot ulcers will have underlying osteomyelitis, and 15% of diabetic foot ulcers will lead to an amputation. Rule of 50, 50% of diabetic foot ulcers with underlying osteomyelitis need amputation. It means 50% of diabetic foot ulcers with underlying osteomyelitis does not require amputation, which can be salvaged. 50% of amputees require a second amputation in less than 5 years, and 50% of amputees do not survive beyond 5 years. Examination of diabetic foot requires only a pair of sensible eyes and hands. In India, it is our tradition to touch the elders' feet to seek the divine blessings. It is a method inculcated by our forefathers on inspection and palpation of diabetic foot periodically. Ladies and gentlemen, examine the foot of your patients and get immense divine blessings. This is a typical diabetic foot, which has all features of it. There is dryness of the skin, cracks, fissures, callosities, increased pigmentation of the foot, AV malformation, clawing of toes, crowding of toes. There is increased web spaces, and significant surgical sign of an ulcer, both in the diagnosis and in the treatment, is the edge of the ulcer. Edge is defined as the junction between the margin and floor of the ulcer. If the edge of the ulcer is sloping, it is a healing ulcer. If the edge of the ulcer is punched out, it is a chronic ulcer, static ulcer, trophic ulcer. If the edge is undermined, it is a deteriorating ulcer. It requires immediate intervention. During surgical debridement, punched out edges and undermined edges has to be converted into a sloping edge for the ulcers to heal. The predominant inference of a diabetic foot examination is to decide whether it is classified as whether it is neuropathic or a neuroischemic ulcer. Just as we have dermatomes in neuropathy, in nervous system, we have angiosome in vascular system. So it will say if the particular angiosome, even in a peripheral vascular disease, if the particular angiosome supplying the ulcer is fed, the wound ulcer tends to heal. I was part of this study on near-infrared optical system to the University of Florida. We did 2 studies. One is to assess the vascularity by using near-infrared optical system for the ulcer. And the second one was removal of the callosity improves the oxygenation to the tissues. The most important cause of non-healing ulcer is the absence of offloading. Management of pressure ulcers is both non-surgical and surgical. The convention is total contact cast. It heals more than 90% of pressure ulcers in 8 to 10 weeks. This is a simple method of offloading called Mantagani method of offloading. What we do is we roll 4 or 5 gloves, wrap it on a gauze and fix it posterior to the ulcer. It offloads the ulcer. Removable cast walker is a commercially available total contact cast, and it is equally effective if worn properly with compliance. It can be equally ineffective if worn only to your clinic visits. These are the other offloading methods. My favorite is walker. Every profession is divine in its own right. We surgeons practice it in both letter and spirit. See, we perform abhishekam to the foot before we complete the surgery. Surgical management involves removal of all necrotic, non-viable tissues until we reach a healthy bleeding wound base. The pus has to be thoroughly let out and deep tissue has to be taken for culture. This is an interesting patient. Patient was fully debridement, everything was done at Pondicherry, and the surgeon over there found the interphalangeal joint exposed on the great toe and was advised amputation of the great toe. Fearing amputation, patient came to us. So what we did is, we wanted to salvage the great toe. So what we did is, we used collagen and elastin matrix along with WAC to salvage the great toe, and the joint was fully covered with granulation tissue, and we closed it with the skin grafting. So this is how we did the vacuum along before applying the matrix, collagen elastin matrix, and then we covered with a foam, and we connected to the VAC. And within 5 days, we got the wound with a fully granulated. So there are many indications for VAC. My take is, if it is an exudative ulcer, and if it is a large ulcer, and if there is no bleeding in the ulcer, these are the places which we generally use VAC, and if there is no major organ is being involved, vital organs are not involved. Indications, as I told, there are many indications, humpty of indications. I would definitely not go for everything, but if it is an exudative ulcer, and if it is, we are going to salvage the preventing amputation, we will definitely go for. And contraindications, as I rightly said, vital organs should not be done, there should be no bleeding. And in necrosis, we should not do VAC, we have to do a proper debridement. Dermal substitutes, there are many available now. What we do is uses collagen and elastin matrix. So it is usually applied when the bones and tendons are exposed, and so that it covers with granulation tissue gets covered. And even in full thickness burns, we can use this dermal substitutes. It gives tremendous effects. Collagen usually used as a filler, and it reduces the scar tissue, whereas elastin is one which improves the neoangiogenesis as well as increases the elasticity of the skin after the grafting. This is a patient of severe necrotizing fasciitis. Patient came in a very moribund state from Kuwait, and the patient was resuscitated, and extensive debridement was done, and a wide split skin graft was done, and patient walked home without a single amputation. This is another patient who came from Srivillikuttur. Patient had a chronic lateral malleolar ulcer. It is developed in the osteomyelitis of the calcaneum and tarsal bones. Patient was advised a below knee amputation, and patient fearing amputation, they came to us. So this is how the ulcer was. So what we did is we did a thorough debridement, sequestrectomy was done, and we used the dermal substitute along with WAC. This is an MRI which shows extensive involvement of the calcaneum as well as the dorsal bones, and the X-ray also shows the similar. And the patient healed well even without a skin grafting. Patient is able to walk with his own feet without any amputation done, and moreover, patient is back riding a scooter and do his work. This is another patient who was advised below knee amputation. So, and what we did was we did a CT angio to find out there is an obstruction in the anterior tibial and posterior tibials, and both the vessels was stented. And what we did was a midfoot amputation, and you can see the difference how the vascularity has improved, and the patient walked home with on his own foot, avoiding a major amputation. This is another neuroischemic ulcer, and patient and his wife both are scientists by profession. And when they developed an ulcer in the third toe, and which became gangrenous, it was amputated by the surgeon without assessing the vascularity of the foot. And next, within 1 or 2 months, less than a month, the patient developed the second toe also gangrenous. Patient became jittery, and they abandoned the surgeon, and they went from one place to another. They went to Kochi, they went to Chennai, and so many places they went, and finally they came to us. And we evaluated the vascularity to be very minimal, and there was no flow. And unfortunately, we could not do an angio or a CT angio or an angioplasty because he was a patient of chronic kidney disease with the urea more than 100, creatinine 7. So we had only one option left, hyperbaric oxygen therapy. And you all know hyperbaric oxygen is 100% oxygen in a closed high chamber, and it improves, it gets dissolved in the plasma, and so that the oxygenation to the tissues increase 3-fold compared to the normal circumstances. And I would like to thank Dr. Priyavardhana who helped me in this patient. And patient, we did give HBOT pre-op and post-op also. In 3 weeks duration, the wound started granulating and epithelialized fully, and the patient smiling happily with this 1 month therapy, problem solved. With 6 months, problem was solved. And this is another patient with a lateral malleolar ulcer. Lateral malleolar ulcers are very difficult to treat, appears to be very simple, very challenging. I was telling about the Srivalli Tipputur patient who was advised a beak amputation, who developed only a lateral malleolar ulcer. Lateral malleolar ulcer appears to be very simple because only a lapis is very small, but it is on the malleolus, so it involves the osteomyelitis occurs. So this has to be treated properly, offloading has to be done, and patient was salvaged. This is a typical trophic ulcer, healed with an offloading. This is another mangled foot, advised amputation, and this also what we did is we did debridement, whack, and wound closed with the skin grafting. Therapeutic footwear is a misnomer. It is only used to prevent the occurrence and recurrence of ulcer and not used to treat the ulcer. I repeat, majority of the pressure ulcers can be effectively managed by non-surgeons, and categorize every pressure ulcer as either neuropathic or neuroischemic before starting the plan of management. Thank you, one and all.
Thank you so much, Dr. Shivakumar, for a lucrative presentation. We can take one question.
Yes, sir. Yes, sir. Thank you, sir.
Mic, please.
Thank you very much. And yes, you guess it's on HBOT.
Yes, sir.
Do you recommend HBOT only for this neuroischemic severe ulcers, or how do you choose patients with diabetic ulcers for HBOT? Because the FDA recommends even for deep osteomyelitis, for many even necrotizing fasciitis.
True.
There are many conditions which
Very
the
true.
FDA recommends.
Yes.
So how do you choose your patients for HBOT?
Very good. Very interesting question, useful question for all public. And I have generally used for neuroischemic ulcers. The reason is the oxygenation improves, because in neuroischemic ulcers, oxygenation is the big issue for the wound not to heal. But as you rightly said, wherever there is more of osteomyelitis, and moreover, wherever the free radicals are more, as Ramurthy sir said, wherever there is more of free radicals, you have HBOT to neutralize it. Okay? And wherever possible, we can definitely use HBOT. It is going to give a tremendous results. And if the patient is compliant, we can use it for any indication for diabetic foot ulcer, more so ever for the ischemic ulcers. Thank you, sir.
Thank you so much. Thank you for this presentation. Now the next topic, we call upon Mr. Anand from Synergy. Mr. Anand?
Yeah, good evening, all of you. And I thank the organizers for giving us this opportunity. So today's topic of mine is going to be on a modern day epidemic and the novel innovations in the field of rehabilitation with which we can treat our patients. So in this modern days, poor posture is a chronic epidemic, and we see patients like data, even 10-year-old children, they have demonstrated spinal degeneration. And these postural malalignments, they even predispose to problems like migraine, high blood pressure, decreased lung capacity, where it deprives the human body of oxygen supply as well. So there is a significant relationship between the bad posture and the early death and complications and pain and agony, what the human community come across. So the functional breath, the core, the pelvic floor, and the low back, they play an integral role, and they have a significant role when it comes to maintaining the quality of life, because chronic stress, anxiety, trauma, injury, and habitual postural patterns, they dim down the natural coordination and activation, which is very much important to address to a lot of perennial problems which we are coming across in this modern era. So what happens is the vicious cycle of inactivity due to some reasons, because of modernization and confinement to the system, we do less of activity. When we are less active, our muscles become weaker. When they become weaker, when we are trying to do some activities, they tend to consume more energy or more oxygen. So then we become breathless. When we become breathless because of the fear, we avoid doing activities which gives more demand of oxygen consumption, and thereby the vicious cycle keeps on running and highly restricting our quality of life. So it is a combination of a healthy core muscles. The diaphragm, it acts as a canister which maintains a proper coordination at the level between the rib cage and the pelvic floor. And the pelvic floor muscles are also an integral part of our rehabilitation. And definitely the lower back also plays a very crucial role. So whenever we are addressing to problems with lower back or pelvic floor, we should also concentrate into the significant role played by the diaphragm and also the core muscles as well. So the musculoskeletal health also takes a very bad beating because of the improper posture, because we slouch, we have shoulder back posture, we have kyphotic posture, we have exaggerated lumbar lordosis and so on. So what it does is basically it reduces the coordination between the rib cage and the pelvic floor, where the canister, the diaphragm, gets highly compromised to move efficiently and to maintain a proper breathing pattern. So this, if the oxygen supply is not appropriate and if the canister, the diaphragm, is not performing its duty appropriately, it decreases the brain threshold, it creates an imbalance, and it creates a lot of movement problems as well. Same way, the most unsung hero in everyday activities is the pelvic floor muscles. The pelvic floor muscles have a very significant role when it comes to organ support, when it comes to sexual arousal and erection qualities, and also it is an integral part of the core, and they are very much important to maintain proper continence when it comes to bowel and bladder functions. So they are the most unsung heroes when it comes to the care of our patients. So the pelvic floor and breathing, they are integral. So when we inhale, the diaphragm descends and the pelvic floor also descends. And when we exhale, the diaphragm ascends and the pelvic floor also ascends. So always there is a connection between the diaphragm and the pelvic floor. So definitely, if for any reasons the patient is having dysfunctional breathing, this will affect how the pelvic floor is functioning as well. So the thoracic diaphragm and the pelvic floor are interlinked. So when it comes to compensation with the pelvic floor, the most common health problems, particularly in women when compared to the numbers what we see in men, are common, like obesity, hormonal imbalance, PCOD, infertility, menopause syndrome, arthritis, cancer due to breast and cervix origin. But of them, the most predominant one is the pelvic floor dysfunction. So this leads to a lot of problems. So these are all integral. Like the back problem, it could be due to dysfunctional breathing. That might influence your pelvic floor functioning. That might lead to urinary incontinence. And ultimately, our patients, due to inactivity of the pelvic floor, they might have some sexual issues with sexual arousal, orgasm, and erectile dysfunction also. So these are all interlinked to one another in one way or the other. And in this modern era, when we have to address our patients to give a better rehabilitation and give a better quality of life, we need to have a clinical toolbox which is efficient enough to approach all these indications in a holistic manner. So for this, for treating this modern day epidemic, we have some wonderful devices, like we have to the left a device called the Spine Empty Core, which is the state-of-the-art spinal decompression device. And to the right corner, you find a deep stimulating peripheral magnetic stimulation device, which can be used for pain management and urinary incontinence, and so on. So let me just give you a little insight. The Spine Empty Core, it's a core of spinal therapy, and it has a core of multifunctional rehabilitation treatment device, which addresses not only to the spine by doing three-dimensional decompression, which all available devices do. This guy, along with the three-dimensional decompression, he also incorporates spinal mobilization. When we are incorporating spinal mobilization, it helps to increase the dural mobility. It regulates the flow of the cerebrospinal fluid, and ultimately it enhances the balance in the autonomic nervous system. When we are doing all this, we are able to increase the range of motion. We are able to increase the functions of the spine. the pain threshold comes very less, and there is increased neural nutrition supply and increases neural conductivity, and the pain is controlled significantly, and the quality of life improves, along with the three-dimensional approach of decompression, which helps to reduce the disc space. So we can have a combined effect of both mobilization and decompression with this device. So when it comes to cervical option, we have a precise selection of the segments, say from C1 to T1. Based on the level of lesion, we can position the patient on the table based on the level of lesion and achieve higher levels of decompression. And if the patient is having unilateral involvement, let us say it is right-sided or left-sided decompression happening, we need to do unilateral correction. That also can be done with a few adjustments on the device. Same with the lumbar also. We can do segmental decompression. And the image which you find on the third one, what it does is there is an air pump which induces sacral nutation and counter nutation. When we are encouraging sacral nutation and counter nutation, like the soleus which we have as a peripheral heart, the sacral nutation and counter nutation also acts as a pump, sacral pump, which regulates the flow of the cerebrospinal fluid to and fro from the brain through the spinal cord. When it is regulating it, it regulates the flow of the cerebrospinal fluid, thereby nourishing the nerve cells and also improving the conductivity of the nerve cells. And there are overlapping chambers which come across the patient's waist, and they are also alternately inflating air chambers inside, which will mobilize the pelvis, and it will prevent anterior or pelvic tilt, and it will neutralize the pelvis before either decompression or rotation starts. So we address it in all various manners, like we are able to do customized segmental decompression. We are addressing to the sacral activation, and we are also correcting the pelvis before either we do decompression or we do unilateral correction based on the picture, clinical picture in front of us. And this helps us to activate, because the thoracic segment, which lies between the cervical and lumbar, has a significant role when it comes to shoulder and neck injuries, neck problems, and also a minor role when it comes to low back issues. So we should never forget about the thoracic segment also. So for that, we have a thoracic mobilization segment as well. So this mobilizes the thoracic segment. If I want to have an isolated lumbar mobilization, I can do lumbar mobilization also. Or for some patients, if I want to combine both thoracic and lumbar, that can also be done. Both will work in a synchronized manner. So by this, we are not forgetting the thoracic segment which lies between the cervical and lumbar, and whatever contribution does higher up and lower, we are trying to nullify that as well by mobilizing the thoracic segment. Then we have Salus Talent Pro, which is one of the premium and powerful electromagnetic stimulation device which will address to various issues. There are various synonyms. We call it by deep penetrating electromagnetic stimulation or high intensity focused electromagnetic therapy, functional magnetic stimulation. These are different names given to this wonderful technology. What it does actually, physiologically, it induces electrochemistry. We will be inducing a high intensity electromagnetic field through the coil. It will initiate an action potential, and when the stimulus overcomes, the cellular depolarization happens and the repolarization process takes over, and that leads to contraction and relaxation in the muscle. So what is very crucial is there are three factors which we need to understand. One is the intensity, second one is the frequency, third one is the interburst or intertrain interval. So once we become a master of these three parameters, we can create our own protocols based on our patient's needs, and we can. Sorry, sir.
Time is over.
It was for 30 minutes. Yeah.
Okay.
So with this, what we can primarily attend is, like I told you, the diaphragm being a canister plays a very crucial role when it comes to pelvic floor muscles integration, and also it has a role to play in general well-being and also in lower back issues. Once if there is problematic breathing, there will be increased stress and inflammation in the body as well. So when we are trying to train the patients on proper patterns of diaphragmatic breathing, we can also strengthen the lower back also in a more efficient manner. We can ensure pelvic floor stability, and when we are maintaining the abdominal pressure appropriately by co-activation of these muscles, we can help to reinforce the strength of the spine as well. So when we are inducing diaphragmatic breathing with the help of the repetitive pulsed magnetic stimulation, we are able to increase the cross-sectional area of the deep spine stabilizers like the transverse abdominals and the lumbar multifidus. So when we are concentrating on improving the breathing pattern of the patients, we are able to improve the balance through deep core control mechanisms and proprioceptive feedback, and this will reduce the pressure on the muscles, accessory muscles of breathing on the neck, and thereby they will support the cervical posture as well. So how we can do this? We can place the pulsed electromagnetic stimulation device when the posterolateral approach from the end of the rib cage, and we can target the diaphragm, and by giving repeated stimulation, we can induce strong contraction and relaxation in the diaphragm, which will improve the activation and coordination and breathing efficiency in the patients. It doesn't stop there, because pain is one primary factor for which patients come to rehabilitation specialists. So we can manage pain based on opioid release theory, pain control theory, and also peripheral pain pattern theory by playing with the frequencies. It also regulates the circulation in the human system, thereby it will overcome inflammation and also relieves neural system and unstable cells. So it can also help to increase the range of motion due to repetitive contraction and relaxations happening. We can increase the range of motion and restore better joint play. And conservative fracture healing also can be done by enhancing the blood flow and by supporting the formation of vascular and callus cartilage. So spasticity reduction also can be achieved by reflex inhibition method with this device. And when it comes to the effects, it has an analgesic effect. We can stimulate the muscle at various levels. We can regenerate the tissue, and it can be applied in rehabilitation medicine, sports, orthopedics, neurology, urogynecology as well. So now, how does it play a significant role in urogynecology, and how significantly it can help in pelvic floor disorders? It can be used in urinary incontinence, all type of sexual dysfunctions, chronic prostatitis, and so on, and even for general strengthening of the pelvic floor muscles. So it comes with a UI chair. All that the patient has to do is go and sit on the chair for 20 to 30 minutes. A deep electromagnetic stimulation will induce strong contractions to the pelvic floor muscles by reinforcing their strength and optimizing their position. Thereby, we are able to optimize the position of the rectum, bladder, and uterus as well. So it's a 30-minute procedure where it induces approximately around 12,000 Kegels.
Mr. Anand, your time is only 15 minutes. You are exceeding the time. No, it's a 15-minute slot. It's over.
Can be fully clothed. It's an operator-free treatment, and there are no consumables also with this. And the success is significant improvement, around 95% improvement in the quality of life. And right from first session, there is significant reduction in the use of the pads for the patient, and they're able to recover well, and 75% progress is happening. Thank you for the opportunity. I represent Synergy Incorporations, which is a pioneer in field of physiotherapy and rehab products, and one-stop shop for all your rehab and physio needs. Thank you.
Hello. Thank you.
Thank you, sir.
Thank you. Our last speaker is Dr. Krishnamurthy, sir. consultant pain physician in UK. He will be speaking on orofacial pain.
Good evening, everyone. Thanks for the organizing committee and especially the people there and Dr. Padma Rani who texted me at 1:30 in the morning to say that, I can use this slot. And as I'm the last speaker, she said I can use as much time till the last person leaves the room, but I'm not going to take more than 12 minutes. I'm an anesthetist basically, but I also do 50% of my job is doing chronic pain. And I have chosen orofacial pain clinic orofacial pain relief because this is what I do as my special clinic with a MDT type of clinic. And also, this is much more complicated and more threatening and more meaningful to the patient than the other chronic pains like low back pain. And so the next slide. Right, as you can see, 45% of the human homunculus is represented by the face, neck, and the shoulders. So that shows how much importance is for the face. This is because when somebody has facial pain, any basic human behaviors like eating, chewing, talking, communication, and also expression of emotions like sadness, happiness, and also intimate activities like kissing, all those things can be affected. So when those things are affected by pain, these patients feel their basic instinct, human behavior is threatened by the pain. So it gets complicated quite easily. So that's why facial pain is more complex and difficult to treat compared to other chronic pains. Simplistically, this is the innervation, the three branches of the trigeminal nerve, and also you get some cervical plexus innervating the neck. And the face has also got enormous autonomic innervation, sympathetic, parasympathetic, all types of ganglions, nerve centers. So the face is rich with nervous system, and this makes facial pain to manifest with autonomic symptoms. This is a lady with burning mouth syndrome. If you can see, the problem is in the mouth, but our entire eyelids, foreheads, they're all red and swollen. That's because of the autonomic impact of the chronic pain system. A few slides on physiology. This is the pain from the facial area is communicated to the cortex through the three sets of neurons, first order, second order, and third order. When there is a problem, say for example in the jaw, the first order goes to the nucleus tractus solitarius of the trigeminal nerve or caudate nucleus, and then there is a synapse. And from the synapse, there are two types of nerve fibers, as Professor Ramamurthy said. Any A-delta fibers, which carries the sharp pain. Sharp pain is like an acute pain, any sharp pain like pins and needles. It goes through the neospinothalamic tract. There are no synapses. It goes straight to the thalamus and to the cortex. Whereas deep, dull aches or a type of chronic pain, it goes through the paleospinothalamic tract, which has multiple synapses. So the speed is very bit slower compared to the neospinothalamic. And also it gets filtered at the reticular formation, periaqueductal gray. So whatever messages that is conveyed through the paleospinothalamic tract may not be exactly what is happening there. So there is a lot of modulations before the pain fibers reach the cortex. So the pain might be different, but what is perceived might be different. And this is again descending inhibition, which is like a braking system for all the pain. Even though descending inhibition works for all the pains from everywhere in the body, it is more affected by the facial pains. And this is one reason why manipulating the descending inhibition system will be more useful in managing chronic orofacial pain. There's also now research papers saying that things like TENS, acupuncture, and even meditation, they kind of stimulate the descending inhibition and help in management of the facial pain. This is another important difference between chronic pain in other parts and the face. We call it as convergence, which is just like our referred pain. You know, when you have appendicitis on the right iliac fossa, sometimes you can feel the pain in the left iliac fossa, something like that. So if you look at that one, the red neurons are from the first and second division of the trigeminal nerve. They synapse in the caudate nucleus, but there are also the green fibers from cervical region. They synapse in the same caudate nucleus. Not only they synapse in the caudate nucleus, they go up and communicate with the neurons coming from V1 and V3. So what happens is, both when the pain messages go to the brain, the cortex might get confused whether the pain is coming from the shoulder or from the forehead. So sometimes when the problem is in the trapezius, the patient might feel pain in the forehead, and this is because of the crosstalk of these neurons at the caudate nucleus. And this happens only in the facial pain because of the lengthy nucleus in the medulla and the upper spinal cord. And this is again another central example of central sensitization, which is quite common in facial pain than in peripheral low back pain or neck pain. If you look at that, you know, when there is a source of pain in the trapezius, for example, when there is a muscle spasm or tenderness or some injury to the shoulder, the nerve fibers not only go to the thalamus and the cortex, but on the way, you know, they can also stimulate the V1 and V3, and then the cortex can send efferent fibers, which can cause contraction of the masseter muscle, for example, in this case. It's called co-contraction. Co-contraction is the type of contraction where the agonist and the antagonist contract at the same time. When the agonist contracts, the antagonist should relax for a smooth muscle movement. But when both agonist and antagonist contract, it causes intense pain there. So basically, the problem is in the shoulder, but then the patient comes to the doctor with intense pain in the cheek or in the jaw. And if the patient goes to the dentist, they might think there is some caries, they might pull the tooth out, but that's not going to solve the problem, but that can make the pain worse. This is the laminated appearance where the pain fibers from the face are just conducted in this laminated fashion. For example, lamina 5 goes down to the bottom of the caudate nucleus, whereas lamina 1. And this gives some features like the pain is always conducted along the lamina. If they have pain in the lower jaw, it goes up to the vertex, and they don't cross to the opposite side. If there is a problem in upper jaw, it can kind of refer to the lower jaw on the same side, but it won't go to the other side. And this shows that the reticular formation modulates each and every impulse coming from the face, and that's why they are susceptible to biopsychosocial influence of pain, which is more common. So if you don't treat facial pain quite quickly, then they are more likely to become chronic pain. And that's because of the influence of reticular formation. So this is our hospital where we have this MDT team, which is formed by anesthetist, ENT, neurologist, physiotherapist, occupational therapist. And this is the referral pattern. We get referrals from dental practitioners, GPs, ENTs, ANEs, and general pain clinics. And this is what this is a data for 2 years. We saw about 300 patients. The most common cause for referral is temporomandibular joint. And then next comes the neuralgias, and then musculoskeletal pain, the third, and then the dental pain, the last one. What we did not see any intracranial pain or sole dental pain as a cause of referral and severe mental illness or anything. So temporomandibular joint and pain dysfunction syndrome, these are the signs and symptoms which can be, which you all know, and it can be treated by non-invasive methods, minimally invasive methods, and also invasive options. This is one reason, just chewing the nails, which can cause temporomandibular pain. And then the non-invasive stuff or stabilization, repositioning. And then these are the drugs which Professor Ramamurthy explained, some of those drugs, antidepressants, anticonvulsants. This is all we use, nothing new. These are the different types of exercises delivered by the pain physiotherapist, chronic pain facial physiotherapist. And then if there is no improvement, we just kind of use combination therapy and also arthrosynthesis, where we put 2 needles into the temporomandibular joint and flush the joint. And we don't do these replacements. And neuralgia is the most common cause for facial pain, and the treatment of choice is anticonvulsants. These are the different treatments for neuralgic pain. And also this persistent idiopathic facial pain is a diagnosis of exclusion. When you have excluded all other causes, treated all other causes, still the patient is having pain, we label them as PIFP. And the most common cause for this is anxiety and depression. And then this is the musculoskeletal causes, muscle spasm with trigger points and things like that. This chart tells you how a small dental abscess can lead to fibromyalgia or a systemic myalgic disorder. It can get better after a bit of muscle soreness and myospasm, or if you leave it longer, it can go into like a regional muscle spasm, and if they don't get the proper treatment, they can go to systemic myalgic disorder, which is fibromyalgia. So it starts from one area in the face, and the entire system can be affected. And these are all the trigger points which can be misleading. For example, if you look at this sternocleidomastoid, I'll just take one more minute. See, that's the sternocleidomastoid, and you can see the crosses are the trigger points. They might have pain there, but sometimes they also have pain around the orbit or on the other side, the cleidomastoid, which is the deeper layer. The problem might be in the cleidomastoid muscle, or and then if you see, the patients can be feeling the pain in the forehead. So what I'm trying to stress is the site of pain and source of pain can be different. So you need to treat the source of pain rather than the site of pain. The site of pain can be misleading. So these are all the various trigger points where you need to put, and these are all the exercises we use. That's nothing new for you. You are using all these things: TENS, ultrasound, temporomandibular joint injection, trigger point, and inferior massage, resistance, moist seat, cold therapy, colon therapy. So we were able to treat about 45% with physical therapies, no medications, just the TENS, acupuncture, massage, and 41% needed small dose of painkillers like pregabalin, gabapentin, and 14% needed outpatient interventions like trigger points and nerve blocks. So that's it. So the message is facial pain can be very complex, and it can be much more meaningful than the other chronic pain. And secondly, because of the intense nervous supply to the face, it can cause a lot of autonomic symptoms. And the third thing is, people can go into anxiety and depression quite quickly if you don't treat facial pain within 6 to 8 weeks. So try to diagnose and treat them early. And the fourth thing you need to remember is the site of pain and source of pain can be different. So you need to treat the source of pain rather than the site of pain. Thank you so much for listening.
Thank you, Dr. Krishnamurthy, for a wonderful presentation. I know treating the pain generator is more important. That is the take-home message. We can afford one question because we are already running late. Okay, I'll ask you one question. When do you do the interventions? When do you plan to do the interventions? Because 45% of your cases you have dealt with physical therapy.
Yeah. So mostly we try the non-interventions first. So we have a physiotherapist and psychologist, and if we can manage them with all those non-interventions. And then if they are still not happy, it's basically, each patient is different. For the same problem, one might get better with the interventions, whereas the other might be, okay with. So we try the non-invasive methods first, and then if they fail, then we do the interventions.
But I'm sure, because these are all the temporomandibular joint dysfunction pains,
Yeah,
right?
yeah.
And if pure trigeminal neuralgias, then you have to intervene.
Yeah.
You
But
can't
not
wait
all
for
cases, some of them can be managed with just medications, just pregabalin, carbamazepine, oxycodone. You need to find what drug works for that particular patient. Sometimes, the pregabalin may not work, so you just try duloxetine, or that might not work, you try oxycarbamazepine. So, and then it also depends on what the patients want, If somebody wants the pain to be completely gone, 100%, then, the failure rate is high. We won't be able to satisfy them. But some people say, I'm okay with about 50% reduction. If I have a good night's sleep, that is all I need, then the success rate is high. So basically, if somebody comes to me, I give them all the choices, okay? But there is no evidence to say that injections are better than medications, or medications are better than physical therapy, or doing nothing is better than everything. So it's pain medicine is, as you know, we can't do randomized controlled trial in pain because there is no, the definition of pain varies from each person, and what they expect as pain relief also varies from each patient. So there are no, so I give them all the choices, and they will ask me, what will you choose, Then I will say, I won't choose anything, because if I get pain, I better go and, I won't go to the doctor. That will be my answer. So what I'm going to choose is not going to help you. So you trial and error, and you find the best combination that works for you. And then sometimes it might take even 6 months before we know what is working for that particular patient. It's all by trial and error.
So this is Dr. Vijayan. You showed a picture of a burning mouth syndrome, and then you left it off. Now, how do you treat burning mouth syndrome, and what is the common
burning mouth syndrome is, again, we start with, psychological, because most of them, if you look into burning mouth syndrome, they have a history of anxiety and depression. There might be a lot of, burning mouth syndrome, irritable bowel syndrome, chronic visceral pain, facial pain, PTSD. They might have a history of PTSD. And also, if you explore the history further, they might have, childhood traumas, sexual, mental, and psychological, insults. And so those things, one of the common causes of facial pain is hidden psychological trauma, during childhood. So you explore, there is a psychologist who will explore all those things. And then you go again treating with medications, the same anticonvulsants and things like that. And they also use some local anesthetic gels, like lidocaine and things like that, which they can gargle. There is also local anesthetic lozenges, like, like a Vicks thing. They can put it in the mouth and keep it, And then finally, if it is still not, they are not happy, we have fentanyl, like a sublingual fentanyl, buprenorphine, or some fentanyl patches, like a lollipops, which can be given for them.
Have you injected Botox, sir?
Sorry?
Bottle them.
Yeah. So we use plenty of Botox. If they don't respond to steroid injections, we use Botox for trigger point injections. We use Botox even into the temporomandibular joint to relieve the spasm. And for headaches, Botox works because the headache patients, they go to neurologists first, they try everything, and then they end up in more side effects from medications, then they come to us. And then we use Botox. There's about 32 points around the scalp, depending on if they have more of frontal headache, you inject more. But I also use ultrasound to inject the Botox, because if you inject Botox too superficial, it's not going to work. And if you inject Botox under the muscle, it's not going to work. So it should go into the muscle, and we use ultrasound to get in. Of course, here we can do it, but lower back, sometimes we think the Botox is going into the muscle, but it won't go into the muscle. So if you inject Botox into the right spots, that gives a good response. So we use Botox quite a lot.
Thank you so much, and thank you.
you.
With this, we'll end the session, and we'll invite all the speakers on the stage.
Yes, ma'am.
For felicitation.
Yes, ma'am. I request
Dr. Krishnamurthy, be on the
sir,
stage,
please stay on the stage, sir. I request our organizing chairman, Challakumara Sami sir, to felicitate Dr. K. Vijayan and Dr. V. Arul Selvan sir. I request our chairpersons to felicitate the speakers of this session. I request Dr. Ramamurthy sir to come to the stage. I request our chairpersons to felicitate Dr. Shivakumar sir. Request our chairpersons to felicitate Mr. Anand from Synergy. I think he's not here. I request our chairpersons to felicitate I request our chairpersons to felicitate Dr. Krishnamurthy sir. I request our organizing chairman to felicitate the chairpersons. Thank you, ma'am. Thank you, sir. With this, we are concluding the scientific sessions of today. We are having our gala dinner at Lee Royal Meridian of Neelambur, and the dinner session starts by 7 o'clock. We have arranged transport pickup from PSG. We have 2 shuttles, one at 6:15 p.m. and another one at 6:45 p.m. I request all of you to join with us for gala dinner. Thank you.